Okay, just before I begin my short speech, this is an introducing slide to the website. So you can see the address rrss.eu is available right now, so you can access. Is open to everybody, but in few days actually it will be available, the documents, the speech PDF or video links to all of you. With all of you, I mean only students and teachers will have the access to the documents, not everybody of course, so you will need to register to the site. And you will receive shortly, within one day, I hope, but within the week, of course, the acceptance for the access of all the speech you heard, all of the slides you've seen, so documents of the school will be available for you, available for downloading and recall them actually. The site will be available for the next month, so you can access to the documents right after the school. And we are planning to create a sort of a forum or a connection with the students, with the teachers, and with the robotic committee of the European Society. The robotic committee is the institution that invented the school with the support of ISART, and a person, myself and other, will collect all your requests and give an answer, keep in touch with the teachers, and if you have any other information you can just ask through the forum. So that's it. And let's start with my short speech, as I said before, and is not pointed to the exactly clinical point of view, but a research point of view. My duty is to highlight the difficulties and issues in research in PRM and in robotic research in particular. You have just seen so many examples of how robotics can improve some features, some EMG recording, some values, but these are singular results, singular point of view, but in research it's completely different, the point of view. The taking in charge and the data you can extract are totally different. So I want to highlight the main issue of this topic, how to translate the robotic uses, the robotic uses to a research plan, a research field. But before the robotic issue in research, I want to point out the issue of research in PRM, because typical and very different from the acute area, physician area or medical area. Here you can see the most recent out of stroke, but it can be compared to all the physician rehabilitation area, and not only stroke. This is a review from Stroke. It's at the journal in 2017, a few months ago, and it highlights the most important issues in PRM research. Here you can see most of them are reliable to the robotic actually, because in rehabilitation area phase of care, We are talking about post-acute care, and the stakeholders are usually may be more important than the clinical needs. That's an issue. It's really important to point out that this issue with stakeholder in the, I mean everybody, not only the payer, not only the robotic producer, not only drugs, but all the stakeholders, caregivers and policies in health management and so on. After that, the recovery and rehabilitation trial are focused on a different time span compared to the acute one. So we're talking about weeks and months and years. So the construction of models of research are very different compared to the acute area. And people working in the rehabilitation knows it, and this leads to a difficult in constructing model of research, but also it leads to face so many social and personal factors leading in high impact on recovery. So it's not only the brain changes that act on recovery, but also so many social factor, money and so on factors. And most of all, behavior. Behavior is changes. So that's why not only robotics, but also drugs, also the environment, and so many factors act on behavior, psychologists, and many different variables. So it's totally different to the acute therapy, to the acute area where the patient doesn't need to behave. You just look for one thing, one result. The benefit is really strict, correlated to a relationship cause and effect. Here is totally, completely different. And also, this model of the rehabilitation models in care and research competes, actually faces, sometimes embrace, but sometimes the dealing is not really good with healthcare business practice. So it's really difficult to deal in such area in a time spanning for months and months. In this case, I want to point out here to resume all the methodological issues in rehabilitation area and rehabilitation research area, of course, because taking out from all I said out of the review from stroke, here I just resume specific issues in rehabilitation research field. Like here, we all face difficulties in blinding, and this is also robotic can help in that, but not as much as in the acute area. Blinding the administrator or the intervention is really difficult and many times is not possible to prepare or to construct as a model. Usually it can happen when you combine more therapies or such as non-invasive neuromodulation added to robotics, for example, but it's very little and comparable to the acute research area. And then in rehabilitation, we face most of the time resistance to the randomization. Patient, they just ask, why should I go under this randomization? I understand, but it takes me months and months to recover and I lose time. So many times they resign, they refuse to sign a consent. And if some of you are involved in research, I bet that you faced this kind of situation. And also the placebo group is very difficult to create. Sometimes you just use tricks like crossover design of the studies, but also in this case you lose time in the mind of patient many times or caregivers. So here are the three main issues faced in a rehabilitation research area. And moreover, the complexity of intervention is another issue that is not comparable to the acute area when a drug is administered or a single treatment, very easy one. Here, all the rehabilitation treatment are really complex. Also, the robotic one may be considered complex in all the phase of the treatment. So usually the creation of a model of a research, of a trial, it is not that easy. And all these points lead to have so many trials, so many studies with a little, very little sample of a patient in rehabilitation research. So insufficiency of samples come from all these issues, actually. So all that I've said, that I have highlighted, create also more topics, more things you have to keep in mind when you consider a research in this area. I mean the length, all that I've mentioned, some confounding factors like the length and the complexity do not give any particular response on the difficulty on split from the benefit from the intervention and from the normal or natural recovery process. From the robotic or from other instrumental treatment, it's easier, but is not avoidable, this issue. And also the uncontrolled factors occurring during trial are very important. Not only the behavior, but external factor. But it's easy to think about that actually if you undergo a treatment lasting for months and months. Also the follow-up lasts months and months. So many factors can occur. So the variability is very high, actually very high. And last but not least, actually in rehabilitation field, in rehabilitation research, the concept of effectiveness and efficacy are really, they can debate, is not really one comparable to the other. I mean, sometimes they face each other. Effectiveness can be considered as the capability of producing to product an effect. So it means how well the treatment you chose to study works in practice. So it can be considered as the external validity. And efficacy is, on the contrary, the internal validity can be considered the internal validity, so it means how well it works in clinical trials. So the efficacy and effectiveness in rehabilitation are not the same. And when you see, when you read studies where you understand that those two words are mixed, you understand that they did not study very well they did not point out very well the internal or external validity of the study. So to enter in particular of the research in gait and in robotic, the use of robotic in gait research, I want to point out only few issues, only few topics actually. In this case, I've just mentioned few scales. Actually, in yesterday, also this morning, but you will hear in the next days, so many scales that are available for gait assessment and for balance and for the use of robotics in particular, or innovative technology in this area. I've just mentioned the most important. Actually, the most important studies or reviews analyze this kind of measure, the Bartel Index, which are very different one to the other. I mean, some of assistants, they evaluate the assistant in independency, outcome, efficiency. So it's the most important area evaluated by these scales. The Bartel Index, the Riverman Mobility Index, the FAC, very, very used and assessed for the efficacy and efficiency of instruments in rehabilitation. About gait parameters, you heard a lot yesterday from Serena, from Dr. Balasciani. All gait parameters are strictly and very well evaluated by the robotics tools available. And the walking distance, there are several scales. The TUG, time up and go, 6 meters, walking test, 6 meters, 10 minutes walking test are the three most important scales, but there are so many actually. And the Fagermeyer Motricity Index. The dots on the last line means that you can find so many others, but those are the most important actually. We have so many scales, so many values to evaluate, to assess, but we also have so many robots to assess, use in research. This is a problem actually, because so many robots, I'm not talking about that, I just want to mention some of them, but what I want to point out that we have so many different instruments that many times this is another big factor of confounding in research, and this should be avoided actually. So many classification of robotics are available. Yesterday you heard already about that, but I want to point out two main differences about robotics available for research or for rehabilitation in general. The stationary system, first of all, divided in exoskeleton type devices, programmable foot and effector devices. You know, most of them, the locomotor, reambulator are the most famous. The gait trainer, Geo system are the most famous as end effector device programmable. And you know already how it works. I just described upside in the slide what it means actually with stationary system. And the other group of robots available in research, I pointed out of most available research studies in literature are the overground walking systems, and the main devices are Rewalk and Exo, Dr. Monteni just described before a few minutes ago, and are available from medial or lateral system, and in commerce there are more robots like Andago and so on, but these are the most available in studies and in literature right now. So what to point out, what is available right now in literature about robotics in gait. Actually, before telling few data, because I chose to give you a few data and with references, and you can look up about them, and I'll tell you why in a few minutes. But before that, I just want to point out that in one thing particular, robotics help us in research and in rehabilitation, because robotics can improve the motor learning phenomenon. And the motor learning phenomenon is why that? Because it comes out of repetitive movement, task-oriented movement, and attention demanding. These are the three most important features of motor learning phenomenon. And it, of course, is not a unique or a statuary phenomenon, unitary phenomenon, but robotics help a lot in all those three features, in repetitive movements or sessions, in improved task-oriented treatment or duties, and it helps attention demanding. So as we heard yesterday from Serena Maggioni. And also robotics can give you, as mentioned before in the slide of measurements, a very highly precise and objective measurement of the treatment of the protocol they are performing, the movement or the session actually. So they give you what do we want to know about the result, how to measure the benefit. We want to measure the movement in gait, but this is translatable to upper limb also actually. We want to measure the movement efficacy, accuracy, efficiency, smoothness, and speed. So these are the most important values we want to evaluate, to improve, of course, and robotics really helps for the first time in this assessment, actually quite safely. So, given all this, so many issues in the rehabilitation research, so many issues in the robotic research, do we have a strong results in literature? Do we have strong founding? Actually, no. Not yet, I must say, for so many reasons. The most important are strictly linked to the issue of the PRM weakness of research, but to talk about, in particular, about robotics challenges. And for the first group I've just mentioned, the stationary system, Locomat and Reambulator, they have great importance, but they have also a limitation in robotic degree of freedoms. And the movements of patient, of the person, are quite constrained in a sagittal plane, so it prevents, for example, balance training. This is quite important, this is very important in gait rehabilitation, actually. So you can have, you can sort out so many data out of movement, smoothness, for example, improvement or ROM, but you don't perform a balance training. You don't have results out of balance training using only robotics. So this is quite important and a limitation, actually. And this is both for Locomat or Reambulator, but these give lead to really conflicting data in literature, actually. The patient in subacute but also in chronic phase of recovery of stroke, but not only in Parkinson's disease and multiple sclerosis, are quite conflicting. Actually, I've just mentioned two two citations, the two reviews from 2014. The first one from Top Stroke Rehabilitation, the Sweden just saying that the use of robotic assisted gait from training devices, different one, including Locobat, did not result in superior imbalance outcome measurement compared to conventional therapy. The other one, the Cochrane review out of the Cochrane database system review 2014, Merritt's very famous one, give a different result, a different observation. In particular, the post-stroke patient undergoing the electromedical assisted gait training in combination with physiotherapy are more likely to achieve independent walking. So you see two reviews, same years of appearance, two conflicting data, conflicting results. So why that? Actually, those are reviews, so are not a particular study or trial, but the important thing is that they considered all the issue I've mentioned before in constructing model or trials available. And also considering that the stationary system like Locomat, very little study are available on chronic phase, in the chronic phase, in particular in stroke actually. They are increasing in recent 1-2 years, so it's thinkable that in coming year or 2 years more structured results will be published. But right now results are really conflicting and really few, the available one. So for example, it's another study, another review that showed that Locomat gave and higher intensity training may produce improvements in walking speed with chronic patient with chronic hemiplegia out of stroke. This is a study, very recent one actually, but the small amount, the small of sample, the sample is small, it is not very high, so it's not considered in the previous review. Similar results also for the reambulator, so it doesn't really matter which robot is included in or considered. When we talk about that, we consider in all the stationary or end effector or overground walking system in these reviews. These conflicting data are very similar to the other robotics devices, like the end effectors as mentioned, or the overground walking system described before in the speech of Dr. Molteni. So the gait trainer and Geo also gave very, very conflicting data. They are stimulant actually, because a gait trainer, for example, in a spinal cord injury stroke patient since 2007, but confirmed later on, showed helpful capacity or give a significant improvement in walking speed or resistance in case of paresis. But you know, considerations are absolutely similar to the others. So you can report, you can report that also to EXO and wearable systems. So I just want to resume this not really happy slide actually. It looks like it cuts hopes actually, because if we look in the literature, actually we don't have enough evidence about gait and posture or balance rehabilitation. Very few evidence, they exist, but still few on motor learning processing or phenomenon. no evidence on sensory motor stimulation or motor imagery, and on robotics, I should say, absolutely not sufficient. So it's really important to consider the last line I just wrote in bold. There are no guidelines. So this is another issue, actually, because to construct guidelines, you need some data from literature, but if you don't have guidelines or models in literature, in research, every center create its own models, create its own studies, so data and studies will be more and more conflicting. So this is very important. These are considerations from Dobkin in 2004, but recaptured by Jose in 2010, the same article mentioned before yesterday in this speech about ethics. And this is really important because it will lead to do not have any cooperation among stakeholders, and this is one I think is the most important thing is in rehabilitation area, not only in research but also in treatment and taking in charge. So to conclude, these reviews, this list of issues in rehabilitation research, robotics and gait in particular. We know from literature that the robotic gait rehabilitation can improve gait parameters, number of sessions, intensity, length, and so on. It also may reduce therapist burden. I didn't mention about that, but many works, many studies are available about that. But we are very far to solve out, to point out any particular result in this area. So guidelines and more structured trials in cooperation among all stakeholders are really, really requested, mostly in this area than compared to the other area of medical research. Thank you.